All right. Good afternoon, everyone, and welcome to today's webinar, Legal Issues in School Health, Scope of Practice, Standardized Data, and Special Topics, brought to you by the Network for Public Health Law. My name is Daniel Wacker. I'm the Program Development Associate here at the Network's National Office, and I'll be your host for today's webinar. We strongly encourage audience participation, so feel free to use the Q&A function down below or at the bottom of your screen to submit questions throughout the presentation. But we will also have time at the end of the webinar for open-ended Q&A time. Your moderator for today is going to be Carrie McGowan Lowry, and I will pass it over to her to introduce the rest of the speakers and begin today's webinar. So Carrie, over to you.
Thanks, Daniel. Hi, everyone. So my name is Carrie Lowry. I'm going to be moderating this session, and I'll also be your first speaker. I'm the Deputy Director and Director for Grants and Research at the Network's Eastern Region office. After I have some brief remarks about, I'm not going to promise they'll be brief. They'll be normal-sized remarks about the importance of school nursing in public health. And I'm going to try to set up the legal framework of school nursing in the US to give you a better understanding of the role of school nursing and the complexities of practicing in a school setting that Kim will really be focusing on. So the next speaker then will be Kim Stanislaw. She's the Doctor of Nursing Practice, and she is the Research, Education, and Practice Director at NASN, National Association of School Nurses. Kim will talk about the role and importance of school nurses, again, the complexities of practicing nursing in the school setting, and then she'll take a deeper dive into the importance of standardized data in school health and some initiatives that NASN has taken in that area. After Kim, Matt Swinburne, who's a public health attorney, also with the Network for Public Health Law's Eastern Region, where he's the associate director. And Matt will talk about one of the hot button issues of the day with regard to school health, and that's the various ways that states have started to handle medical cannabis in schools, the legalization of medical cannabis in the school setting. And we will leave some time for questions at the end. So next slide, Daniel, and I'll get started. Next slide, that's just my title. So I'm going to cover a little bit about the Network for Public Health Law and NASN's partnership and kind of how that developed and where it has led, the resources that it's led to. I'll talk a little bit about why school nursing is so important for public health, and then I will start to explain the legislative landscape of school nursing, specifically state laws that affect access to school nursing services and state laws that affect the practice of school nursing. Next slide. So the network's partnership with NASN began in 2016, and it came out of work that I was doing in the space of traumatic brain injury and return to play laws. And the partnership began in an effort to research and publish resources on laws that affect school nursing in general. So we have prepared a number of resources. The link to those resources is down at the bottom there if you're interested in checking them out. But we have 2 primers on navigating the intricacies of data privacy in the school setting, data sharing in the school setting. We have a report on health and attendance and the impact of chronic absence, the role of school nurses in managing concussion, Medicaid payment for school nursing services. And then we also have a 50-state survey. It's actually a 51 jurisdiction survey because we include DC on school nursing scope of practice and ratio laws. That was last updated in 2017. We have a 2023 update that is about to be published once quality assurance is finished. Next slide, Daniel. So this is just a look at the kinds of laws that we capture in that resource. Again, obviously the state, but the Nurse Practice Act and the citation to the Nurse Practice Act in that state, if there is one, whether the state requires a school nurse, that's the ratio law. So does the state require a certain number of school nurses per population, or does the law not specify whether school nurses have to be available at all? Is there a minimum level of training that's required for school nurses or for endorsement as a school nurse? And then we have this whole section about whether state law expressly permits delegation of duties to other school personnel who are not registered nurses, and then whether the state law expressly permits the school nurse to screen or test for things like hearing, vision, BMI, and other nutritional standards and other. Next slide. With this presentation, really going to focus on data related to whether the state requires a school nurse and ratio laws, and specifically on whether the state law permits delegation of administration of insulin and glucagon, or inhalers or epinephrine, and the newest kind of burgeoning area, naloxone in the schools. Next slide. So the next couple of slides, I'm going to go through this pretty quickly because I know that Kim is going to touch on some of this as well. Registered school nurses really are a largely untapped national resource for public health. We know that education is a strong indicator of health outcomes. Ensuring positive academic outcomes for kids is an important public health objective. We know that U.S. chronic disease burden has its roots in preventable childhood exposures like nutrition, tobacco use, and physical inactivity. RSNs are uniquely positioned at the intersection of student health and education, and they're trained to understand the complexity of the relationships among physical and mental well-being and educational attainment. These school nurses really present an opportunity also to reach kids where they spend a majority of their time. Next slide, please. Registered school nurses provide access to prevention services, early detection services, mental health for school-aged kids and adolescents, especially in rural and urban areas where better child health can help break cycles of health inequity that exist there. And for children in these areas, for many of them, the school nurse may represent their primary healthcare provider. Next slide. So now let's talk about the legislative framework in which nurses practice. So state laws affect access to school nursing services with very few exceptions. Laws across the country really have not recognized the critical role that school nurses can play in improving health and well-being for kids. For example, only Delaware requires a full-time registered nurse in every school. That is the standard that American Academy of Pediatrics and NASN would push for. Only one state does require that by law. Many jurisdictions require districts to share a school nurse or don't have one at all. And we know that sharing a school nurse across districts is not ideal for many reasons. You know, there are the obvious reasons, but also nuanced things. If you think about, you know, a school nurse who sees a kid on a regular basis, you know, say they have a student who routinely comes to them with a stomach ache. With repeated interaction with that child, they may come to realize, like, actually, I think this kid may have some kind of an anxiety disorder. But a nurse that doesn't have that kind of relationship with the child because the nurse is not there on a regular basis may not be able to build that connection. Next slide, please. So the first category of laws that we look at are ratio laws. So again, American Academy of Pediatrics recommends one full-time nurse in every school. Healthy People 2020 actually set an objective to increase the proportion of elementary, middle, and high schools that have full-time registered school nurses to at least 1 to 750. So one nurse to 750 students. Healthy People 2030 actually reframed that objective to increase the proportion of secondary schools with a full-time registered nurse who provides health services to students. It's the Working Group on Adolescent Health, and it's a research status R08. So research status for Healthy People 2030 means that it's a high priority public health issue that doesn't yet have evidence-based interventions developed to address it. It may actually become a core objective within Healthy People 2030 with the availability of both baseline data and evidence-based intervention. Next slide, please. Here, I just wanted to show you, this is from Healthy People 2020's mid-course review. I spliced these things together, so this isn't the way it looks If you look up the actual report, I just took the ECBP 5 data, which is the stuff that's related specifically to school nurses ratios, and linked it with the table title. But you can see that the green check mark means that the target has been met or exceeded mid-course of Healthy People 2020. So schools with a nurse to student ratio of at least 1 to 750 in K through 12, senior high schools with a nurse to student ratio of at least 1 to 750, and elementary schools with a nurse to student ratio of at least 1 to 750 were all deemed to have met or exceeded that target. Middle schools with a nurse to student ratio of at least 1 to 750, there was little or no detectable change. Next slide. So this could be why the shift in 2030 is to secondary schools. So talking about ratio laws a little bit more, we know that around 25% of US schools offer no nursing support at all. Ratio laws are those laws that require a certain registered nurse to student ratio, try to address this. And as of April of 2023, about 21 states require some level of school nursing services by law, which means that 30 states do not. Again, we have more than 50 there because we count DC. Next slide, please. Only 11 states require certain staffing ratios for general student population. And these are just a couple of examples. So Georgia law requires 1 school nurse per 750 elementary school students and 1 school nurse per 1,500 middle and high school students. Arkansas requires 1 school nurse per 750 students and 1 to 400 in districts with a quote, a high concentration of children with disabling conditions. The law also stipulates a penalty, which is unusual. We haven't seen that in many of the states. It places schools or districts that fail to employ a nurse in a probationary status. But in Arkansas, these ratio requirements depend on availability of state funds, and that's written into the law, which kind of takes the teeth out a little bit. Next slide. 3 states encourage but do not mandate a ratio for general student population. You see this a lot in public health laws where we know that this is a good practice, but it's expensive, so we're going to encourage you to do it. And it's written into the law as something that's encouraged but not required. No enforcement, very little teeth with those kinds of things, but at least it's there. For example, Oregon requires ratios for medically fragile or complex students, but only encourages a ratio of 1 to 500 for other students. So the requirement in Oregon is only for medically fragile or medically complex students. Utah encourages local education agencies to provide school nurses for 1 to 2,000 students. And Virginia law requires school boards to provide at least 3, quote, specialized support positions. And the law defines that in a way that can include school nurses, but can also include a host of other kinds of positions like school psychologists and the like. Next slide. So the next area of laws that we have looked at are delegation of nursing services. I'm sure that Kim will talk about this some more, but this is a real problem where you have untrained folks who are authorized by law to do very sensitive and complex medical procedures that actually require quite a bit of training beyond what can be offered to school personnel. So one of the key areas here is medication administration. Most states allow any trained school employee to administer epinephrine. Epinephrine, and I'm sure, Kim, you can touch on this, but my understanding is that at least with an EpiPen, there isn't much risk of doing severe damage to a child. And so this one seems to be a little bit less controversial among the medical community. Alaska allows a school nurse to delegate administration of injectable medications, including EpiPens, to a certified medical assistant. So it can't just be any employee of the school. It has to be a certified med assistant, but only if the RN is on site. Insulin and glucagon is kind of on the other end of the spectrum in terms of potential to do damage to a child if it is if it's administered improperly, right? So several states, and I've just listed a few here, allow, just like EpiPens, any trained employee to administer insulin and glucagon. Next slide, please. Naloxone and opioid antagonists, this is a burgeoning area. So we're seeing more and more states that are allowing stockpiling of naloxone in the schools and that are writing laws that allow school nurses to delegate authority to administer naloxone, or that just straight up allow anyone with access to the naloxone in the school to administer it. So Illinois allows trained personnel to administer naloxone, and Indiana adds that piece about stocking naloxone in the school and also allows trained employees to administer it. There's also this whole new area of legalized medical cannabis and how to handle that in the schools, and Matt is going to talk to us about that later on. Next slide, please. So really just quickly wanted to touch on two other legal issues that impact school nurses. The first is telehealth and training requirements. So 2014 study found that rural school nurses were twice as likely as non-rural school nurses to provide clinical services to many schools. They're less likely to hold a nursing degree at the bachelor level or higher, and they're less likely to have received recent continuing ed on anaphylaxis, asthma, healthy weight, diabetes, and suicide prevention. So laws that enable training and service delivery via telehealth are potentially really important in order to close these gaps in rural areas. Next slide. Oh, they're also very inconsistent across the country, which is important to note. Another legal issue is Medicaid billing for school nursing services. The ability to bill for Medicaid for school nursing services varies widely by state. We do have a resource that is slightly outdated at this point. We need to update on the network's website. Massachusetts allows school nurses to bill Medicaid for all Medicaid eligible services through their state amendment plan that was approved by CMS in early of 2017. Some other states like Florida and Kentucky only address Medicaid reimbursement for healthcare services that are listed in a child's IEP. And a lot of states actually do that. Next slide. So finally, I just wanted to again reiterate, this is where this is the landing page. This is what it looks like. And this is where you can find all of our school nursing and the law resources on the network's website. So please feel free to check those out. The next slide is my contact information. But then without further ado, I'm going to turn things over to Kim Stanislaw, who is Research, Education, and Practice Director at NASN.
Thank you, Carrie. We're going to talk now about some of the practice complexities that come from the laws that Carrie discussed, and look at how standardized data can help us in school nursing better support the need for school nurses and advocate for our role. Next slide. When we think about the role of a school nurse, this actually comes from the definition of school nursing from NASN. So we protect and promote student health, facilitate optimal development of the students. We advance academic success by bridging healthcare and education. We promote and provide care coordination. We're advocating for quality student-centered care, and we're collaborating with many within the school system as well as the community to promote systems that truly support students' full potential. Next slide. When we look at some practice considerations that are very different for the school or educational setting versus working as an RN in a hospital or medical setting, these are just some of the differences that we deal with that at times can cause some ethical dilemmas as well as some legal dilemmas and why many of the states do require or recommend additional education for school nurses, as this is not necessarily information that is gained through an RN education. So when we look at the role description expectations of a nurse, those are very clearly defined in a hospital setting, as well as the levels of nursing. When we go into the education setting, the nurse is a nurse is often what is understood of a nurse. So whether it's an LPN, an RN, an advanced practice nurse, a nurse is a nurse is a nurse. However, that also can be the person sitting in the school nurse's office or the clinic who may not be a licensed nurse, but is referred to as the nurse. So that is a definite issue that we run into. As far as nursing supervision and evaluation, there are very clear standards in a hospital or medical setting about who can evaluate and supervise nursing practice. However, in the school setting, many school nurses are actually supervised by non-nurses and evaluated by non-nurses. This causes an issue as the majority of nurse practice acts discuss an RN's practice can only be evaluated by another RN. So that does also lend itself to some issues. In a hospital or medical setting, there is a standardized orientation and typically mentor or training period, not only when you're first hired into the facility, but typically when you move from floor to floor or specialty to specialty. In the school or educational setting, there's often no orientation unless it is a very large district with a school nurse supervisor and they have an established program. However, in the majority of districts where there may be one school nurse or maybe a nurse who the district just hired one, but they have not had one previously, none of this is in place. So there's no orientation as well as no training period. It's kind of the Wild West. You're going in there and figuring it out yourself, hoping that you are doing the best you can to support those students and following not only the nursing laws, but also the education laws. Again, that's one of the reasons why the states promote some specialized education for their school nurses. In a hospital and medical setting, care is very team-based. It's very collaborative. There are resources in place, whether it's supplies, whether it's education, and the models of care are very clearly defined. That, you know, there are physicians, there are nurses, there are unlicensed personnel, and their roles are very clearly defined. In a school setting, the school nurse is working completely autonomous. There is, unless, again, it's a large district, that school nurse is working completely alone with very little resources and sometimes limited supplies and limited education. It can be very isolating as the only healthcare professional working in a non-healthcare setting, where it's often the role is misunderstood or misinterpreted what the role is. In the models of care, there may be an RN over a district of 20 schools, and maybe there's an unlicensed person in each one of those schools, where in a hospital setting, that's not happening. Same with LPNs. How the care is distributed, that model of care looks very different than what would be expected in a hospital setting. You know, we do have some delegation in the hospital setting, but in the school setting, we have delegation as well as designation due to some of the education laws. And we are delegating and training for designated staff, which is typically the law states that the school district or the superintendent designates staff to do this, which means the school nurses provide training, but we're not actually delegating it. An example here in Ohio, medication is actually designated. So we provide training, but we're not delegating that to unlicensed staff. And we often end up delegating things to unlicensed staff that does not happen in the hospital setting. Insulin is one of those where, in a hospital setting, a dose of insulin is often checked by 2 licensed professionals before it's administered. However, in the school setting, it can be provided by an unlicensed staff member without any double checking. Obviously, in this medical or hospital setting, we follow the Nurse Practice Act that guides our practice. But in the school setting, we have not only the Nurse Practice Act, but education laws that are not taught in nursing school. So they are specific to the practice of school nursing and something that needs to be considered and the nurses need to be aware of outside of what they would consider their typical practice. And sometimes these education laws and the Nurse Practice Act can conflict, and that has to be dealt with through school policy and sometimes some advocacy to get some things changed. Privacy laws in the hospital and medical setting are HIPAA. In the school setting, however, we deal with FERPA, which has to do with educational records. There are some instances where we deal with HIPAA. However, it is typically FERPA. So again, that is another one of those issues that coming from a hospital or medical setting that the nurse would not be necessarily prepared to understand. Next. So when we think about these complexities, it can really cause a lot of misunderstanding of our role, as well as putting the nurse in a position where she may not or he may not fully understand what they're getting themselves into or what they are responsible for without having access to resources like the National Association of School Nurses or resources on the state level. So it is very important to make those connections. And for some states that have contracted service, either through public health departments, private agencies, or hospitals, it's also very important that those employers who are contracting these services understand these issues to better prepare the staff to go into the schools, as it's not something like in the hospital where a floor may be short on staffing and somebody's floated from another floor. That's very difficult to do from hospital to school, again, because of some of these issues. Next. So when we think about school nursing, a lot of what we do, we advocate for our value. Not that we're not important, we are extremely important. However, as Carrie mentioned, a lot of the requirements for school nursing are based on budgets, and budgets come down to value. So when we make the connection between public health and education, school nurses truly add value, not only looking at the public health outcomes of it and the population health, but looking at student success. So things that we look at that are also looked at within public health, cost of care, public health is also looking at life expectancy, mortality rates, prevalence of chronic conditions, and screening rates. And school nurses are doing much of that work within the school setting as well. When we look at student success or educational outcomes and the academic indicators that school districts are held accountable to, some of the most common or well-known outcomes are student test scores, graduation rates, attendance rates, and school climate. And we have quite a bit of work going on right now here at NASN related to school nurses addressing chronic absenteeism and being able to promote the students being back in the school setting where they can learn and thrive. Next. When we look at the role the school nurse plays, again, the combination of the public health and the education, we think about serving the whole child, not only the academic, but the student supports. And Those student supports as seen here, there are social, emotional, and behavioral health, physical health, safety and climate, and family and community engagement. Those are all dependent upon non-academic barriers, and they're very influenced by non-academic barriers. And this is an area, again, where the school nurses have great value. Next. So these are some examples of what those non-academic barriers may be. So when we look at public health in general, these are all topics that public health works to mitigate, prevent, promote well-being for. School nurses are also doing this on the school level. So the partnerships between public health and the schools are often seen in the role of the school nurse. And each one of these non-academic barriers are often not funded for intervention by schools, where test scores, attendance, graduation rates, those barriers to the academic side typically are funded. So if a school nurse is in a district or a school and we can address some of these issues, it greatly helps student success. Next. So when we look at the top barriers to learning, again, this is the connection between the public health and the education sector. Students who deal with mental health and behavioral problems, vision problems, hearing problems, lead exposure, dental pain, uncontrolled asthma, food insecurity and hunger, and lack of access to a medical home or healthcare services in general. These are identified as the top barriers to learning. So when we think of public health and the role of the school nurse, all of these things can be mitigated by finding funding for the role of the school nurse and fully understanding the role so that that nurse can support student outcomes, both health and academic. Next. So we're going to look at a quick look at our use of standardized data through our National School Health Data Set, Every Student Counts, and how these data points can help school nurses not only identify our value for the district, for the students, but also in public health, and create opportunities for how this data can be used in conjunction with public health data to truly support population health. Next. So our National School Health Data Set is more of an initiative than just data points. Its goals are to identify best practices in school health, but then also support data-driven policies in advocating for the needs of the students, providing evidence-based school nursing care, and improving student health outcomes. Next. And the reason this data is important, because standardized data provides us the opportunity to speak a common language, whether that's for education, whether it's public health, health in general. Learning to link health data points to academic data points allows for these common conversations to happen and everybody understand the reason we're having the conversation and the benefits. Next. So this initiative is based off of a 3-tier system. So very similar to how public health functions. We have the national, which would be us here at NASN. We have state, whether they're state affiliates, state departments of health or education, and the local level, which are the frontline school nurses in the schools and districts. And the data is most actionable at the local level. So it's very important that the schools and the school nurses at the local level understand how to collect the data, what data they have, and how to utilize it to better support student outcomes. when we have that strong at the local level, the state data, when we combine all of the local data, has much greater value and is more actionable. And as we get data from each state at the national level, then our data becomes more actionable at the national level as it's built up from the local level. Next. And we have a three-prong approach. So we're not only looking at the data points, which are standardized definitions, but this initiative works to build school nurse capacity in understanding data, how to collect data, how to utilize data, and looking at data infrastructure from how is the data collected, what types of systems are used. There is often a disconnect between the thought of how we document in nursing using an EHR, in a healthcare setting, that's standard. In a school setting, there are still many nurses documenting on paper. So collecting data or retrieving data from paper is much more labor intensive and not as effective. So we're looking at all three prongs as we work through this. Next. So these are, I will go through these quickly. We have several categories of standardized data, and these are examples of all of the data points. Looking at things like chronic absenteeism, some of the demographics like free and reduced lunch, English language learners, but we also look at workforce related to education, models of practice, and credentials. Next. And from the models of practice, we are also looking at the FTEs provided for each type of provider. So whether it's an RN, LPN, LVN, or a health aide or unlicensed assisted personnel, are they providing direct services, supplemental or float services, special assignments like a one-to-one with a student, or more administrative and supervisory? So we do collect data by type of provider and how many FTEs are currently being provided with the school budget. Next. Chronic conditions. So we not only look at the number of students who are chronically absent, we look at the number of students who are chronically absent by each one of these diagnoses. So asthma, type 1 diabetes, type 2 diabetes, seizure disorders, life-threatening allergies, and ME/CFS, which is myalgic encephalomyelitis chronic fatigue syndrome, which is a diagnosis we are working with the CDC with through a contract to help identify the prevalence of ME/CFS, which is typically seen in students who are absent with very vague symptoms. Although we are finding that some of these symptoms are actually very similar to long COVID. So the timing is very good in that schools are seeing a lot of students chronically absent with these vague symptoms. Next. And we're looking at the health visits and how many students are sent back to class versus sent home or needed to activate local emergency services. We do this by provider, and the return to class is very important because that's what links to learning time and attendance. Next. So when we think about these data points, using our data platform, this is an example of last year's, the 21-22 school year's national overview, looking at all of the data submitted on a national level. And some of the visuals that we can provide, which can be very helpful to when looking at public health initiatives and the entire population, where this is looking at the school community population. And of note, particularly with the health office visits, we do see that the RN sends more students back to class than the LPN, and then typically the unlicensed personnel are sending more students home than the LPN. So we do see that the education and the preparation does have an impact on student learning time, which can then impact all of those academic indicators like test scores, graduation rates, attendance rates. Next. So when we look at data in general, every assessment that we do, we document data. However, when we pull all these data points together, we are able to advocate using that data for things like general awareness. What do we do? Do the districts or staff, parents, students, do they understand the role of the school nurse? We have data to show that. Value and efficiency to student outcomes, whether this is the return to class, how many medications were given, how many trainings were provided, those services that allow the student to function in the school setting, regardless of whatever health conditions they may be living with. Acuity levels. So whether that's looking at both the staffing available, the models of care, and looking at how many students have health conditions and what care they need based off of that health condition. And staffing needs and models play a large role in the services available to the students and the impact that we can have on their health and academic outcomes, but also in the larger impact of population health when we're looking at the health of a community. Next. So I think this quote sums things up rather nicely for the connection between health and education and the role of school nurses. So poor health not only results from lower educational attainment, but it can also cause educational setbacks and interfere with schooling. This is a problem that has been identified. It's not going away. It differs by geographic region and the social determinants of health. The school nurses play a primary role in helping to mitigate this. Next. And this is just a visual to better illustrate, again, that important connection between health and education and how public health supports both. So there are many opportunities where school nurses can partner with public health departments, community resources, and agencies. But we also advocate that the interventions and programs that are being done in the public health sector and by community partners, please feel free to reach out to the school nurses in your area. Do your schools have school nurses? Who are they? How many are there? What does their model of care look like? How can those partnerships be built to better support overall population health? Next. Okay, thank you very much. This is my contact information, and the next slide will be some of the references, and thank you for your time.
Good afternoon or good morning, depending on what time zone you're in. I'm Matt Swinburne with the Network for Public Health Law, and I'm going to talk today about how cannabis legalization is affecting this issue of medical cannabis access at schools. But before I jump into that, I have studied cannabis legalization from a public health lens for a few years now, Carrie, I think probably. And I really look at these changes in policy and how laws and regulations can be crafted to reduce the risks of this policy change, but also maximize, potential benefits. And, I think cannabis is an interesting topic because you have concerns about its recreational use, but at the same time, the majority of states have legalized it as a form of medicine. And so, laws and regulations kind of struggle with these two systems at play. And so, from a youth perspective, when we look at legalization, we're worried about, increased youth access, increased youth exposure, because we know, children are especially vulnerable because of the important stage of cognitive development they're going through. And, we're worried about the health impacts that this exposure might have. But at the same time, and this is an issue that has been growing, is, as a medicine, pediatric patients, may need to access that school. And how do we deal with that process? So next slide, please. So cannabis policy is changing rapidly, really rapidly. And as it's changing, new issues are being identified. So if we look at almost 20 years ago, only 10 states in the country allowed medical cannabis. None of the states allowed recreational use or adult use. And so this is fairly early on in the process. But next slide, please. You look now, kind of the lay of the land has changed considerably, with 38 states and DC allowing medical cannabis. And this needs to be updated because Minnesota, I believe, just passed their adult use or recreational cannabis bill. So now we have 23 states and DC which have legalized cannabis for adult use. And so this is something that every state has different policies, because as we know, at the federal level, cannabis is still an illegal Schedule I substance. And so each state is its own kind of contained system of rules. And so you get a lot of variation on how states address different issues. And so, every state's medical cannabis system, which is what we'll be looking at for the next couple minutes, varies on key variables. So what I'm going to do to kind of prep us for looking at medical cannabis in schools is kind of give an overview of, how a pediatric patient would be certified to receive medical cannabis. And so there are just a couple key concepts I want to review before we start talking about the school environment. Next slide, please. So in any medical cannabis state, well, any but 3, and I'll explain what I mean by that, to be certified to receive medical cannabis, the pediatric patient has to have a qualifying condition. And those conditions are usually defined by law. And I just did a presentation in New Jersey last week. So I was like, why don't I give New Jersey as an example? I don't know if anybody here is from New Jersey, but these are the qualifying conditions that have been approved by law for medical cannabis treatment. And you can see there's a broad spectrum of conditions and symptoms here. Now, if we look at the medical cannabis system as a whole, not just pediatric patients, the majority of medical cannabis patients are receiving medical cannabis for the treatment of chronic pain. Now, I haven't seen any data that looks at, kind of what pediatric patients are being certified for. But I know a lot of the school bills, when states address this issue of medical cannabis in school, it focuses around students with really severe health conditions. And a lot of these bills are named after specific students. And you see a lot of, these students suffering from fairly severe seizure disorders and getting medical cannabis to treat that. So number one, you've got to have a qualifying condition. in most states, and this list of conditions varies from jurisdiction to jurisdiction. Now, there are 3 states that don't define the qualifying conditions by law. They just say it's up to the discretion of the medical provider. So, for example, in Maine, Oklahoma, and I believe Virginia, the certifying provider just has to, in their professional opinion, believe that the healthcare benefits from a medical cannabis outweigh the potential negatives from this course of treatment. And so there isn't as much kind of government involvement there. Next slide. So if a patient has one of these conditions, qualifying conditions, they can't just go to a medical dispensary and pick up cannabis. They have to be certified by a healthcare provider. Now, it varies from state to state on which healthcare providers are authorized to make that certification. Now, you may see some jurisdictions where it's very limited and it's just a doctor of medicine that can do this. In other states, it's broader, where it's essentially any healthcare provider that has prescription authority, even though, they are not prescribing medical cannabis, because that would be against the law because it's a Schedule I substance. The legal basis for this certification, and I could nerd out about this, is the First Amendment. They're having a protected conversation under our First Amendment protections for speech. They're not using, kind of the power granted to them, for example, with their DEA number to prescribe. So, in New Jersey, the healthcare providers that they've identified are doctors of medicine, doctors of osteopathic medicine, physician's assistants, and nurse practitioners. Now, in any state, you need to be a practitioner in good standing. Some states require the provider, if they want to certify, to enroll in the state program. So they have to register with the state. There are a few states that don't require that. Now, once, you are one of the, authorized providers, you have to have, an ongoing relationship with this patient. And so this idea that this is language used in a lot of states, that the healthcare provider has a bona fide doctor-patient or provider-patient relationship. This idea of ongoing assessment, care and treatment, and, there are often legal restrictions about what needs to be done to qualify for that level of involvement. So it's not what people fear in terms of a pill mill approach to this. Now, pediatric patients, in some states, their certification process is the same as adult patients. But in other states, pediatric patients are dealt with differently. They may require, authorization from multiple physicians rather than just one. And in New Jersey, there's a good, example of this here. For a pediatric patient to be certified, a pediatric specialist has to certify that patient. So if, let's say, the primary care physician, wants to authorize them for this, they have to get a secondary opinion from, let's say, a pediatrician or a pediatric oncologist for that child to get access to medical cannabis. Next slide, please. Now, 11-year-old kids aren't going into medical dispensaries to purchase their medical cannabis. In any medical program, there's the concept of caregivers. And it doesn't just apply to children. This applies to adults who, because of their medical condition, can't access medical cannabis and may have trouble administering it. But in the case of pediatric patients, it's usually parent or guardian. They register with the state and they're responsible for acquiring and administering the medical cannabis to the child. Now, the number of caregivers a pediatric patient can have varies from state to state. So in New Jersey, a child can have, the standard is 4 caregivers. And if they need more than that, they can petition. There's a medical reason. But the idea is, well, maybe the parent or guardian isn't available to administer the medicine. Maybe the grandparent or the uncle is someone who could be registered as a caregiver to administer the medication. Now, these are important concepts to understand when we look at how medical cannabis functions in the school. Next slide, please. So when states, this idea of medical cannabis in the schools and the need, for pediatric patients to have access it during these times is not something that has been baked into the original laws when states are making medical cannabis systems. This is something that, unfortunately, states are developing later on in their systems. And there are key questions that the state needs to look at when they're designing their system. Are they going to make this a permissive or a mandatory policy? For example, we're going to allow schools to establish a system for administering versus we're requiring all schools to have a program that facilitates the administration of this medication. How are schools to verify, the patient and caregiver that they are indeed allowed by law to have this? What type of cannabis products are going to be allowed in the school environment? Who's going to administer the medication? Are we going to just have that, caregiver, parent, guardian? Or are we going to allow school staff or school nurses to administer? And there's a lot of these questions like, will we allow cannabis to be stored at school? Will we allow it to be stored overnight? What are the security protocols? How do we deal with adverse events associated with this medication? So there are a lot of questions that states really need to look at. And so we're going to look at 2 sample states just to give you an idea of 2 different approaches that have been adopted. Now, this is an area I'm interested in, but I haven't been able to do my obsessive compulsive legal epidemiological study. So going through all those 38 states in identifying which states have a policy and how those policies vary on key variables. So we're going to look at New Jersey and then Maryland because they take 2 very different approaches. Next slide. So in New Jersey in 2015, they passed legislation that allowed students to have access to medical cannabis on school grounds, aboard the school bus, or at school-sponsored events. But you'll see in red, the policy authorizes parents, guardians, or primary caregivers. So this isn't requiring school staff to administer. So this is probably, of states that allow medical cannabis in schools, from an administrative standpoint, this is the easiest approach. Because what's required here is that the parent or caregiver has to come onto school grounds or the school bus to administer the medication and then leaves with that medication. So you don't have to worry about the issue of storage or identifying, school staff to administer. Next slide, please. So as part of, New Jersey's, law, they're saying that, for all schools have to have this, both private and public schools. But for, a school's policy, the local school board's development of the policy, you've got to have, you can only do this for registered patients with registered caregivers. And, these caregivers have to be explicitly authorized to give this medication at the areas that were outlined in the bill. But the local jurisdiction has to determine where that should be administered. Is this something that's only allowed to be administered in, the nurse's office? And, one of the key things, and this is something you'll see, every policy I've looked at prohibits the smoking or inhalation of a cannabis product. So a pediatric patient isn't going to be administered, medical cannabis through a vape rig or by smoking a joint. We're looking at tinctures, capsules, transdermal patches, oils. So something that, a lot of folks have come to me as well. Does this mean kids are going to be smoking a joint in the nurse's office? I haven't seen a jurisdiction that allows a smokable product in the school grounds. All right, next slide, please. So here are resources. So as New Jersey was developing this policy, since the law required local school boards to develop the policy, sample policies were being put out to help them with this. And, tools were being developed because they realized that this adds a layer of complexity to what, schools and school nurses need to deal with in the educational environment. So, if this is something your state is considering, there are resources out there, in states that have already tackled this issue. Next slide, please. And now, Maryland's an alternative approach. We differ a little from New Jersey in that we only require public schools to have a policy. It's permissive for private schools. And we had our Cannabis Regulatory Agency and the Department of Education create a series of guidelines in terms of what school policies have to include in Maryland. Now, I'm going to go very quickly because I realize we're over. Next slide, please. And I'm just going to point out some of the key differences. Now, in Maryland, someone at the school has to be available to administer the medical cannabis. So it's not just a parent or guardian. Someone who's part of, school staff has to be trained to be able to do this. Now, some folks with the natural choice would be the school nurse, but as part of Maryland's law, and in other laws I've looked at, you can't force a school nurse to administer medical cannabis, against their will. And so in Maryland, if the school nurse is unwilling to administer this, the school has to identify another staff member who would administer it on school grounds. So along with this, kind of big change, there's also the additional challenge of, well, we're allowing it to be stored and we have to have security protocols on campus, and we're going to allow it to be stored overnight. So we've got to have security protocols linked to that. But, this is just a different approach to the same issue of trying to make this medicine more accessible to kids to facilitate their access to their education. Now, I apologize because I realized I went a couple minutes over. And so last slide, there we go.
Awesome. Thank you, Matt. And thanks, Kim. Daniel, you came off video. Did you want to say something?
I was going to say, if we want to, we can have a couple minutes. I can stay on for some question time if you three have time as well.
Yeah, great. Definitely. So, Daniel, I don't know, I put the link in there for where we put our past webinars. But there were some questions in the chat about whether the slides would be made available. So I put the link in the chat. I'm not sure if we routinely send a link to all of the attendees. Is that a thing?
Yeah, so in about a week, we'll have a full recording of this webinar as well as the slides sent directly out to all the participants. So you should receive an email directly when those materials are available.
Amazing. See you guys, our national office is amazing. So we actually had, if you have any pressing questions or even not pressing ones, please feel free to put them in the Q&A or in the chat. But we did have a really good question about liability for school nurses and in general, how to get boards of nursing and the profession in general to acknowledge the extensive liability that school nurses carry as individuals. And the question also linked that to The idea that if school nurses were more aware of their own risk of being sued individually and in conjunction with the school, that they might be more involved in legislative advocacy. And the questioner referenced NASSN's legislative priorities. This is definitely a big problem. There is some conjecture that school nurses may be at a higher risk for liability, mainly because of their professional isolation that Kim talked about. You know, unlike practicing in hospitals or other healthcare facilities, school nurses are often the only licensed medical professional on site. So they bear the bulk of the responsibility, right, for medical decisions that are made on behalf of a child, which also means that they bear more of the liability for decisions that don't end well, right? So it's essential that school nurses provide care according to their school policies, but also according to their practice standards and within their scope of practice, and that everything be documented thoroughly. So Kim mentioned FERPA. We have a lot of information about FERPA. There's some sticky stuff there, right? So like FERPA requires for minors that parents have access to anything that is contained in the child's medical record, and that includes reproductive health services that are administered by a school nurse because they're considered part of the educational record. And so that leads to some temptation to not document, right? Because if you don't document it, it's not part of the record. And so thoughts are not part of the educational record. So if a parent comes to a school nurse and says, you know, did my kid come to you and ask for contraceptives today? If it's not in the educational record, that's not covered by FERPA. And so there is a temptation that's kind of created by the federal law, right, to not document certain things. And yet documentation is both a part of good standard of care, and it is a part of protection from liability. So there's some tension there. We at the network have largely focused on the legislative and policy side of school nursing law and not on litigation. But if this is an area of interest, then we can certainly take on the issue of liability and litigation, addressing, you know, both what is the true scope and nature of that threat? Is that a real threat? Maybe using some case studies and providing some general guidance for school nurses. We cannot give legal advice because each of us are only barred in the states that we're barred in. So we would be committing our own kind of malpractice, legal malpractice, if we were to provide legal advice outside of the states in which we're barred. But we can give some what we call legal technical assistance, just kind of describing the litigious environment that's out there for school nurses and giving some general means for protecting oneself. We could also look at the legislative approaches to mitigating liability, so using things like the doctrine of qualified immunity and the like. So thank you for that idea. It's definitely a huge issue. Hopefully by talking about it on this webinar, we've exposed at least some of the people who are going to be listening to this to, you know, get out there and to advocate for the legislative priorities that will help school nurses, including liability. So yeah, keep an eye out for those resources. We'll definitely look into creating those.
Carrie, if I could add something from the school nurse perspective. So this is another area where, and I'm not sure I know of anybody collecting data on these school specific cases, but this is an area where that standardized data really comes into play and helping us define what we do, why we do it, and the impacts of what we do. And, you know, we are a specialty practice. In a court of law, we're going to be held to what the prudent school nurse would do. We all know prudent. So you will be held to the scope and standards of school nursing, again, which is a specialty practice. And Nurses not familiar with that will still be held accountable to them. So we find in our work with the data and explaining who we are, advocating for our value and the impact we have when we support student health and academic outcomes, it is a process within nursing as well as outside of nursing, where the data and the school nurse voice has great importance, because it is a two-sided coin that we have to provide this education about the role.
Thanks, Kim. So we had another question related to the litigation issue from Krista Varga. So she says, when a school nurse is named in a legal action, please discuss our potential resources and what the nurse's next step should be once they're notified that they may receive a subpoena. So again, we cannot give legal advice, but as a friend, I would just tell you your first step should be to contact legal counsel in your state that has some experience with malpractice law. That should be number one. And then the first step, anytime someone, the second step, anytime someone is named in a lawsuit is really to review your documentation of the incident in question. And make sure that you have all of your ducks in a row and that you can describe exactly what happened from your perspective. Andrea Tanner says, great point, Kim. Standardized data helps school nurses tell our story, both the benefits we can impart and the risks we take. Awesome. Any other questions? Sheila Caldwell put a link to NASSM's 2022 Scope and Standards 4th edition in the chat. Thank you, Sheila. Okay, seeing none. Thank you everyone for your time today. This has been a really interesting and I always learn something, even though I think I know the things. I learned a lot today. So thank you all for being here, and we'll look into the liability resources for sure.
Yeah, and just to follow up on that, I just want to thank everyone for today's participation, especially our panelists. And just a final note to attendees, like we mentioned before, an email with a link to the slides as well as a recording of the webinar will go out in about a week, and you'll receive that directly. Also, I want to welcome everyone here to our Public Health Law Conference this fall. Here in Minneapolis, where I am currently. We have 5 amazing tracks. Carrie will be presenting. If you want to get another treat of Carrie, she'll be there as well. But I just want to welcome you all, and our registration link is down below. But other than that, that concludes today's webinar. Thank you all for attending, and have a great rest of your day. Thanks, everyone.